Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on HealthcareNOW Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning into the Tate Chronicles. Join me as we attempt to cut through the fog that exists at the leading edge of healthcare technology. Our mission is simple. We're searching for beneficial disruption in healthcare from emerging technologies. I'm very pleased today. My guest is Dr. Gary Price. Dr. Price is a board-certified plastic surgeon, serving as an attending surgeon and clinical assistant professor of surgery at Yale-New Haven Hospital. He's past president of the Connecticut State Medical Society and the Connecticut and New England Societies of Plastic and Reconstructive Surgeons. Dr. Price holds an MBA from the Yale School of Management, and in addition, he's a board member and current president of the Physicians Foundation. Dr. Price, welcome to the Tate Chronicles.
Thank you, Jim. Good morning. It's a pleasure to be here.
Just in the last few weeks, really recently, I've become aware of the Physicians Fund. And I tell you, my interest is really captured by the aspect of an organization that would represent the physician's voice in a lot of different areas. And so I appreciate you joining us today to discuss this organization. As the president of the Physicians Fund, could you tell us a little bit about the organization and how you initially got involved?
Sure, Jim. The Physicians Foundation was founded in 2003, and it's a nonprofit that was funded by a class action settlement on behalf of all the physicians in the United States. It has roughly a $120 million fund that we use to pursue our mission, and it's supervised by a board who represents 17 of our state medical societies and 3 of the county medical societies in the United States. As far as I became involved over 10 years ago when I was asked to represent the state of Connecticut on the board, I've served on multiple committees, including strategic planning, finance, physician practice, and I became president just over a year ago.
How long is the typical term as president for the organization?
There is no specified length of term, although the president has to be reelected every 3 years.
Wow, yeah. What are the goals of the Physicians Fund?
Our main goal is to empower physicians, Jim, to lead in the delivery of high-quality, cost-efficient health care. We seek to do that by funding education, research, and infrastructure investments, which we hope will educate physicians in leadership skills, track physician and patient perspectives on our evolving healthcare system, as well as reveal the role of social drivers of health and healthcare costs and quality. And in addition, we want to analyze the elements of physicians' work which support or detract from their well-being. We really think that we can apply that knowledge to increase the fulfillment they should be obtaining through their practice.
I imagine that there are a number of different sectors or areas that you're involved with. It sounds like things that are directly involved at the point of care, such as technology, as well as more overarching concepts like public policy and potential regulation. Do you get involved in all those different areas?
We definitely do, Jim, because each one of those things you mentioned, as you rightly pointed out, really impacts how care is delivered at the point of care, in the trenches, if you will. All of those things can have fairly dramatic impacts on how a physician and patient work together to improve their health. So we think those are all important areas. And our key sort of defining point of interest is where the physician's perspective and voice can really help the system work better. I think history has taught us that when that voice is ignored, we run into all sorts of inefficiencies and problems.
You know, and as far as the grant process, in your research, in the Foundation's research, do they really come up with proposals for different grants and ask for requests for proposals to fill those grants, or do you just accept grant requests? How does that actual process happen? How does the sausage get made?
Yeah, that's a good question, Jim, and we try to keep it as far away from the sausage analogy as possible. We actually have a very rigorous process that starts with our strategic planning every 5 years, where we attempt as best we can to determine the areas where the physician's perspective will have a critical impact on healthcare in our country is delivered. After we do that, our grants committee, with input from the board, develops areas where we want to publish requests for proposals. That's formally done in areas that we have interest in. Those proposals that come in then, of course, are reviewed by our grants committee and ultimately approved by our board, which consists of both practicing physicians and medical society executives. We do accept proposals that aren't part of our regular grant cycle process, so we are open to that, but we do have a fairly deliberate and rigorous process for funding the projects that we've identified as of critical importance to our patients and our physicians.
You know, one of the areas I know that you fund is related to health information technology. And in my experience working in that field, I often see developers more involved with the software than a clinician. And I would tend to guess that you probably agree with me. There needs to be more provider input into how these systems are actually designed and the user interfaces.
Well, you probably couldn't have chatted with anyone this morning who agrees with you more, Jim. I'm still somewhat dumbfounded that arguably the largest and most important industry in our country, healthcare, could have a tool like an electronic healthcare introduced globally into the point of service of a complex system without really adequately looking into how it would impact how that product was delivered, if you will. I think we've learned that really was a mistake, and the Physicians Foundation definitely believes that if we can get more physician input into how those systems are designed, that we can make things better for everyone.
You know, in my experience as a clinical manager of a large specialty practice, which are pulmonologists, and in support of those physicians, they go in and they see a patient, and then they go to what we call the back wall where the radiologic images were, and they would gaze out the window, and they would, I won't say go into a trance, but they go into a certain mode, and they would dictate into the recorder. And that's how they recorded the clinical encounter. And they were trained that way. They had done that for decades. And then all of a sudden, in one fell swoop, we took that out of their hands and put a computer in their hands. So there was a gigantic cultural / emotional / psychological change, and that was never addressed at all. And I always felt sorry for people who were pushed into that position. You've probably seen that quite a few times in your career when that's happened.
Well, I think that was definitely an issue, Jim, but I think the problem went beyond that in that, the EHR is a tool, and it certainly has incredible upsides to it, but it was introduced with really very little attention to how it would affect the efficiency, the quality of the interaction between the physician and the patient, not to mention the well-being of the physicians using it. I don't think the auto industry would ever invest the kind of billions that were invested in EHRs without figuring out how it would impact the outcome on the production floor, and yet we did that with EHRs. It's a serious problem. I think early on it was written off as perhaps older physicians who were unwilling or unable to adapt technology, but the Foundation and many other organizations have done research to show that that's really not the problem. This problem affects younger and older physicians alike, and it's become a major issue as far as the problem with physician burnout is concerned. A majority of physicians, over 50%, cite the EHR as the major frustration in their workday.
And when a EHR system is selected, you're often selecting something that you really don't know if it's going to work well for you or not. There's so many out there, and again, some are more intuitive than others. So you're almost buying something before you know what you bought. So that can be very difficult. Well, we've talked some about the great frustrations in health information technology. Let's talk some of the greatest benefits. really even maybe beyond the EHR, but some of the benefits of the EHR that you found in your experience?
Well, Jim, as you probably know, the Physicians Foundation surveys both physicians and patients about their perspectives on their health care. And there's no question that both physicians and patients value very highly the ability to get access to the data easily. And, of course, that's a huge benefit to both groups. So I wouldn't want to discount that. I think that's the biggest benefit. Of course, going forward, to share information about patients' care is going to be critical as at least a large segment of our healthcare switches to more of a value-based system. That's really where we see the great potential upside for the health information interoperability fund that we've created.
And I look forward, I'll ask you some specific questions about that in just a minute. When I was an implementation individual putting systems into practices, we always tried to lead with the things that were really positive to a practice, such as e-prescribing and messaging and prescription refills, and again, receiving labs electronically. It's where you got over to the side of the actual clinical encounter documentation that things got fuzzy and frustrating and difficult. It's been a mixed bag. And when I was speaking with somebody recently, they said, well, all this health information technology is like a utility is being built. And it is being built, but it's being built through our active dynamic healthcare system where deliveries of healthcare is being presented and used every day. So it's disruptive in a good way. It's also disruptive in, unfortunately, some bad ways right now. 10 or 20 years from now, hopefully, as you say, we'll be in a much different place. Well, you mentioned the Interoperability Fund. I know there was a recent announcement about a new initiative called the Interoperability Fund. Tell me a little bit about that, please.
Well, this is a really exciting project that the Foundation's thrilled to be able to help with. The state of Kansas, through their medical society, through an arm of the medical society, an organization called CAMCO, they developed a model interoperability system that allowed even small practices to gain access to data across their whole state with a network of both hospitals and physician practices. And they were able to implement this with hardware that could relatively easily be connected to smaller practices and give those practices and those physicians access to the broad data that was available to much bigger institutions with much larger infrastructure. So the Foundation has an interoperability fund for 6 states, Connecticut, New Jersey, Louisiana, Missouri, and Georgia. So we have a really broad geographic diversity there. And the effort is to help overcome one of the barriers to implementing, to help those practices with the cost of actually connecting to the network and having the hardware to do that.
That's always been the concern, that the small and or rural practices are going to be left out of this, to the detriment of the patients that they're trying to care for. In your experience, in your practice, what have been some of the common pain points related to interoperability?
Well, of course, the biggest pain point is for a small practice, the financial cost of trying to become part of a network. For smaller practices, the upsides might not necessarily carry the financial reward that justifies the initial investment. And, of course, smaller practices are under tremendous pressure right now anyway from all sides. So you have that financial barrier. Then there's the actual physical barrier with the kind of equipment that would allow you to do that with whichever EHR your practice happens to be using. And then third, there's access to the larger networks. There's been a lot of incentives built in the system for hospitals to consolidate into much larger networks, and access to their data systems often is only possible if you become part of that network in a more direct financial way. So that can be a huge barrier, that there's just no network to connect to. we think the interoperability project has overcome those barriers quite nicely, and we're very excited about that access becoming available to the smaller practices.
And has that initiative actually kicked off yet? What's the status of it?
It has kicked off. Practices are joining in all of those states. We're starting to see momentum with more and more practices joining. And as they do, they get access to all the data on the network. We are very hopeful we can get hospitals to join it as well. The system definitely supports that, and it would allow physicians to have access not only to other physicians' data in a seamless way, but also to laboratory facilities, hospital networks, et cetera.
One thing that I've seen is that, of course, the ability to download some health information on a particular individual is a great thing, but also the ability to upload. And so there are different ways to, if I go see a family practice physician in a rural area and they do, whether it's just a well patient visit or there's something that needs to be dealt with, after that EHR, after they perform that EHR clinical documentation on me, one would hope that data would automatically be uploaded. There are ways that it can almost be mandated. I'll give you an example. I live in North Carolina, and a Medicaid provider is actually a law that's been kicked around for a few years. It's been extended, but a Medicaid provider, if they see a state Medicaid patient and bill, they have to upload an interoperability file, a CCDA, to the state health information exchange, or they don't get paid at all. It's a 100% penalty. Now, that's been delayed a couple times. It's actually supposed to go into effect at midnight tonight, May 31st, 2019. It's probably going to be delayed by the governor. So there are, as we saw with meaningful use incentives, there was carrots and sticks to get people to use EHRs, and now we're moving to the MIPS and MACRA CMS schemes for reimbursement to kind of push this, but some states are starting to really mandate this interoperability. Are you seeing that, or could there be pushback against that across the country? Love to hear your thoughts on that.
Well, there certainly is pushback from physicians in smaller practices on many of these quality measures, Jim, because many of them require a significant amount of additional time with data entry, and often can appear extremely irrelevant to the patient's care to many physicians. And there's a lot of frustration involved with that. In addition, as our healthcare system has consolidated in part, it's become much easier for large systems, of course, to participate in data exchanges like that. One of the things we're excited about the interoperability program that we're supporting is that it allows smaller practices actually to easily, actively participate in that kind of quality data sharing. So it levels the playing field a bit. We know that around 50% of HealthcareNOW is in those very large consolidated systems, which can cope with those government mandates much more easily. But the other 50% is still in smaller practices, and there's a lot of economic data available now that shows that they actually are a financially very viable model that can compete with those larger organizations if they can access and participate in the data network. So we see that as a key part of that going forward.
I think the tide is, whether we call it coming in or going out, the tide is moving, and there's no doubt that there's not going to be a rollback of this whole push towards electronic health information and interoperability. Let me switch gears on you just a minute. But I know you mentioned there's part of the Physicians Fund is polling providers and patients on different matters. What seems to be the thoughts out there on this gigantic move to value-based care? Used to be fee-for-service. You do an X-ray. A provider may be reimbursed a certain amount. We'll take Medicare as an example because that's the largest reimburser for healthcare services in the U.S. And so the payment would be based on fee for providing that service. And now we have this value-based care come in, which is based on some different quality measures and other aspects of trying to grade quality of a particular provider or practice. What they receive may be more or less based on how they score on some certain quality measures. What's the thinking out there about the macro MIPS program?
Well, as far as macro MIPS goes specifically, Jim, I think physicians have a lot of reservations about it because, as we were talking about earlier, many of those quality measures at the point of care either really decrease efficiency to enter or seem fairly irrelevant. I think there's no question, as you said, that the value-based concept is going forward, and I have no doubt that in certain areas of healthcare it probably will work as a model. On the other hand, I think this notion of defining quality by the boxes that are checked on an electronic form is going to prove to be very difficult to show that saves any money or that it improves outcomes in a major way for many parts of the care that get delivered. So I have my reservations about that, and I think I reflect the thinking of many physicians about that. It's tremendously complicated, and very few of those measures have been objectively shown to actually increase the quality of health outcomes. So I think there are a lot of challenges going forward. I do think if we can provide the tools and the access to the data sharing for a smaller practice, at least attempting to cope with those requirements will be much easier for them. But I think there needs to be way more attention put on the actual on-the-ground, in-the-office effects of all these requirements and measurements. Because every one that's introduced has a direct impact on that interaction between the physician and patient in their exam room. Our surveys show that patients now very much understand that there's a third person in the exam room with their physician, and in large part they view that as the government. Interestingly, the patients believe the physicians are the ones who should be having the most influence on how that third party is brought in when we ask them in surveys. Ironically, physicians feel that their power to influence that has been completely taken away. So we have this huge separation between the patient's expectations of what their physicians can do to influence their care and a total frustration on the part of the physicians with their ability to do just that.
You mentioned we've been discussing the interoperability fund. Just to be clear, this is really a totally new initiative for the Physicians Fund, correct? I mean, this is a whole new area y'all seen the importance of, and so you've kind of jumped in with both feet to provide some direction and not just research, but some actual actions to try and deal with some of these interoperability areas.
Absolutely, Jim. In fact, we funded research in various areas of technology and even funded some major initiatives in attempting to influence the infrastructure in the distant past. But we saw this as a technology that really could be game-changing. This ability for a practice to easily tap into this broad network of healthcare information really can transform the way that they can compete to provide high-quality care in the healthcare that we deliver over the next 10 or 20 years.
Well, the time is kind of rushed right past. It's hard to believe it's almost gone. But before we say goodbye to the audience, how can someone find out more about the Physicians Fund and keep track of what you're doing there?
Well, there are excellent resources on our website, which is www.physiciansfoundation.org. And there are links to our grants, to our past research, to organizations we work with. So lots of great information there.
Well, I appreciate that, and I'll keep a close idea on the Physicians Foundation, especially this new interoperability work that you're doing. Well, it's time for us to say goodbye. Thanks to our audience for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest, Dr. Gary Price. Dr. Price, thanks for coming in today.
Thank you, Jim.
You can find more information on this show's program page at HealthcareNOWradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.